Very good evening, all the students. Can you update me? Is audio video fine? Can we start with the session? Very good evening, everyone. Welcome to this session of fast revision for your FMGE examination. Kindly update in the chat box, is audio video fine? Can we start with the session? I will try my best. In the next couple of minutes, I will be giving you, but in this 1 hour, I'll be giving you all the expected MCQs for your upcoming FMGE examination. Any query you can ask in the chat box. Very good evening, Dr. Shivraj, Dr. Prem, very good evening. Let us start. Everything is audio video fine. Just give me 1 second. So all my FMG students, I will be trying my best. In the next 1 hour, I will be giving you the important topics which are worth remembering, which are the important MCQs. Every student, just do one favor before your FMG examination, beta. Just go through this video nicely. I tried my best to compile all the expected topics in this session. So myself, Dr. Deepak, will be starting with this session. I am showing you the first image, beta. In your FMG, what they can ask you. There is a high probability they will ask you about the incision. So you should be confident of all the incision we are using in our ear surgery. We can use Rosen incision, R-O-S-E-N. Just remember Rosen incision. This Rosen incision is for which part, beta? It is for which surgeries? If we are doing stapes surgeries, stapedectomy, stapedotomies, we are using this incision, Rosen incision. Just remember, this is the first incision I am showing you, Rosen as stapes surgery. Clear? Stapes surgery. Then the examiner can show you this type of incision. Anybody who can tell me what is this one? X is your incisura terminalis, where I am giving the incision is known by the name of Lampert incision. Is known as Lampert incision. Examiner can ask you important point. Which patient we are using? We are using in pediatric patients. I'm understand. I will not be wasting your time in unwanted things. We will be concerned. This is the last spell, and I want everybody should go through the important expected MCQs. Last few days, beta, only academics, only learn, revise the topics in a fast mode, because we want to touch 150. Am I understandable? Are you getting this? Post auricular behind the pinna. If there is a post-auricular incision, this is used for mastoid surgery, and the name is your Wilde incision. Name by the name of Wilde is again preferred. One is mastoid surgery. Yes. So examiner can ask you what is the role of Wilde incision in tympanoplasty. So just remember, in pediatric patient, if I want to do tympanoplasty, I'll be using Wilde incision. So this type of 3 important expected MCQ. Rosen for stapes surgery, Lampert for tympanoplasties in pediatric patients. What is the other indication of Lampert? We use in all canal surgeries, canaloplasties and all those things. Clear? Then coming on the next slide, important topic. Cartwheel appearance, beta. Examiner will show you a bulging tympanic membrane. Can I ask you one MCQ? Yes, Dr. Anish, very good evening. Bulging tympanic membrane, always have 2 things in your mind. Either it can be serous otitis media, that is your glue ear, or it can be ASM. Clear? So your FMG examiner, he is fond of asking the treatment of serous otitis media or ASM. How you will differentiate? You will differentiate with high grade fever. There will be high grade fever. There will be cartwheel appearance. This is a typical finding of ASM in pre-suppuration, stage of pre-suppuration. Clear? So ASM, one is pre-suppuration, one is lighthouse sign. These are the important points. If the examiner asks you the management part, Tommy, where anterior inferior, in ASM posterior inferior, in cirrhosis media where we insert a grommet with what other structure I can remove? Adenoid. Adenodectomies are done because ET tube dysfunction is one of the important cause. Am I understandable? Clear? So either the examiner will be asking MCQ on cirrhosis media or ASM, what will be a key factor? Focus your eyes on the key word in the MCQ. This is not the time to go in the depth of the topic, beta. I will not waste my time. Just focus on the key word. Bulging tympanic membrane, cartwheel appearance seen, congested, high grade fever, ASM. I will go for Laryngotomy. I'll be going for Laryngotomy. Clear? Coming to the next segment. Examiner can either show you this type of slide, beta. Just try to learn. Foul smelling discharge, blood stain discharge, and there is a disease in the upper part. We call it as atticoantral. And if there is no foul smelling, profuse discharge in the disease in the lower part is known as tubotympanic ear, safe ear. Anyone who can tell me this is my X, this is Y. Can you tell me what is the treatment for X and Y? We're waiting for a response. I'm waiting for a response in the chat box. What is the treatment of X and Y? Treatment of X. What is a X? Is a foul smelling. X is your the keyword. Which keyword will be there in the MCQ? There will be foul smelling discharge, blood stain discharge, and upper part of the ear will be involved. Par flaccida, attic, aditus, upper parts will be involved. We call it as atticoantral ear. Atticoantral beta. This is known as tubotympanic. This is known as tubotympanic. So what is the treatment of tubotympanic? Yes. What is the treatment of tubotympanic? Will be tympanoplasty. With tympanoplasty, they will ask you the treatment option. Tympanoplasty with OCR, ossicular chain reconstruction with OCR. What is the treatment of unsafe ear? Atticoantral. Always remember MRM, modified radical mastectomy. Which type of MRM? This is a canal wall down procedure. So we are doing canal wall down procedure, modified radical mastectomy for atticoantral ear. Atticoantral ear. They can raise a MCQ on the complication. And what is their favorite choice? Favorite choice is most common extracranial, most common overall complication is here mastoiditis. They can show you this image which is known as ironing of the mastoid beta. This is the earliest sign. I am expecting one MCQ in your next exam. They can ask you the hallmark sign. If they ask you hallmark sign, it is sagging of the canal. Sagging of the canal. Clear? Very nice response in the chat box. Tympanoplasty, Dr. Parnav. Absolutely yes, beta. Tubotympanic ear, we are doing tympanoplasty. Sagging of the canal, hallmark finding of mastoiditis. Either they will ask you the diagnosis or they can ask you important abscess. Start topic beta. Yahan pe you will make a start. This MCQ can be there. Abscess along sternocleidomastoid. I will label it as basalt abscess. If abscess is along digastric, it will be Critalis abscess. If abscess in the external auditory canal, I will label it as Lux abscess. And what is the most common? Most common, always remember, is your post-auricular abscess. Most common is post-auricular abscess. If you have attended my class, you have attended my class, you have my basic simple notes, you have concise those notes with a ENT in the last spell game of 1 hour. In 1 hour, you should revise in a very fast mode. One MCQ which I am expecting, they can show you this type of CT examination better. Either they will give you this image of CT or they will give you this image of CT. So what is this one? This is empty delta sign, lateral sinus thrombosis. If they show you this CT, it is a second most common intracranial complication, that is brain abscess. Which lobe is involved? Temporal lobe is involved. So I will attempt temporal lobe abscess. This is the first MCQ I'm showing you, temporal. In this session, I'll be giving you 20 MCQs. Along with 20 MCQs, I'll be giving you the all important topics. Very humble, very friendly request. Go through this session nicely before your exam. Clear? So this is your temporal lobe abscess. Is the second most common. So which is most common? Most common is meningitis. Most common complication of here CSOM, extracranial mastoiditis, intracranial meningitis, overall mastoiditis. Always remember. Clear? Empty delta sign is a feature of lateral sinus thrombosis. They can either give you few keywords. Which are the keywords you should remember of lateral sinus thrombosis? Empty delta sign. There will be a spiky fever, which is known as picket fence fever. Spiky fever, picket fence fever. There will be edema over the mastoid. If there is a edema over the mastoid, we call it as Graysinger sign. Your FMG people, they are fond of asking important signs. So Graysinger sign is the edema over the mastoid. But if there is a edema over the retinal vein, we call it as Crowback sign. Crowback sign. Clear? So just have these important points in your mind. What I am showing you, this is a blood clot with a perforation. This is traumatic perforation. Traumatic perforation. What is the MCQ? Traumatic perforation. Treatment is wait and watch. We wait and watch for how many months? Anyone who can update in the chat box? Awesome response coming in the chat box. Wait and watch. The way you are responding in the chat box, it means you have revised the notes very nicely within 3 months, beta. Just remember the golden statement: traumatic perforation heals within 3 months. Heal within 3 months. Clear? Then examiner can ask you important landmarks. So either examiner will give you McEwen's triangle. What is McEwen's triangle? Above your external canal. If you touch the area above external canal, this is McEwen's triangle. This is for mastoid surgery. This is for mastoid surgery. Or they can ask you Donaldson line. Where is the Donaldson line used? Always remember, Donaldson line is used for endolymphatic sac decompression. Endolymphatic sac decompression. Clear? So this is an important MCQ. Coming on the next few important audiogram beta. The first segment I have taught you, they will ask you the infection of middle ear, either ASOM, CSOM or complication of CSM. In the last examination, they have given nearly 18 to 19 MCQs of ENT, and this is the first topic which I have covered you, that is the infection part. Clear? Coming on the next segment, what I am showing you, this is a typical finding of pure tone audiometry. Yes, which gap? I am showing you ear-bone gap. So make a rule. Ear-bone gap is a feature of conductive deafness. How much is the ear-bone gap? Ear-bone gap should be more than 15 decibel. This is the important point for conductive deafness. Clear? And if the examiner show you this type of graph, now this aware before. If examiners show you this type of graph, this is my cutoff marking, that is 25. Yes, very good. It is conductive hearing loss. That is your ear-bone gap. If the ear bone and ACBC both are beyond, it is sensory neural deafness. How you differentiate? Just remember, sensory component we differentiate with moderate deafness, moderate in the range of 60-70. Neural will be severe deafness, more than 80 decibel. Always remember this segment. Clear? Now I am showing you one slide. This is a reddish tympanic membrane. So if examiners show you this slide with this slide, maximum hearing loss at 2000 Hz with red tympanic membrane. So it is otosclerosis. Very important topic. Otosclerosis. What I am showing you, this is your short sign. This is your short sign, flamingo pink sign. Short sign, flamingo pink sign. Dr. Meet Patel, it is not rising sun beta. Listen carefully. Listen carefully. It is a red tympanic membrane. If I give you this image and I ask you, okay, beta, the patient is having reddish mass behind tympanic membrane and which blenches on pressure, this type of history examiner have to mention. Red tympanic membrane as such, we should, if the examiner show the red tympanic membrane, we should have 3 possibilities in our mind. One is rising sun, very good, accident, or it can be short sign, or it can be your cartwheel appearance. But high grade fever, cartwheel appearance, that will be ASO. Now with this slide I am showing you the Carhart notch, so I'll be going more in favor of otosclerosis. If I show you this slide only, yes, absolutely, it can be a possibility of rising sun sign. Very nice feedback you have updated in the chat box. Very good. It can be rising sun sign, it can be short sign. Clear? Now in this image, if I want to choose one, if only this image is shown to me, there is some fullness shown in the tympanic membrane, I will be preferring rising sun sign. But if this image given with a Carhart notch, that is otosclerosis. What surgery we do? Stapedotomy is always better than stapedectomy. Clear? Stapedotomy better than stapedectomy. Drug of choice is sodium fluoride. Pregnant female, MCQ of ENT, go for otosclerosis. Always remember. Clear? Coming to the next, what I am showing you, this is a very favorite topic of your FMG people, maximum hearing loss at 4000 Hz. If examiners show you maximum hearing loss at 4000, always remember it is noise induced trauma. Noise induced trauma, they will ask you the guidelines of the WHO and Indian Factory Act. WHO is 85 decibel, 8 hours in a day, 5 days in a week. What is Indian Factory Act? It is 90 decibel. Just remember, rest everything is same. Absolutely yes. This is your boiler's notch. This is your acoustic dip or boiler's notch. So they can ask you WHO criteria. Now the next slide, next topic. Up to this point was your audiometry MCQs. They can ask you tympanogram. What is tympanometry? Tympanometry is a investigation of choice for conductive deafness. Is a investigation of choice for conductive deafness. Beta, just try to learn. Last few days before your examination, just touch the topic, get the important MCQs and jump to the next topic. Beta, we have to win this game. So these 5 possibilities are there. This is normal tympanogram. This is B tympanogram, which is seen in flat, also known as flat tympanogram. It is seen in glue ear. When there is a fluid, we get flat tympanogram. C is ET tube dysfunction. It is for ET tube dysfunction. And AS or AD, they are very favorite MCQs. These are hypomobile or beta, this is hypermobile. Can you appreciate? Y-axis is the axis of movement, so this is hypermobile. This will be seen in ossicular damage, therefore graph is known as AD graph. And this type of graph will be seen in otosclerosis, therefore graph is known as AS graph. Clear? Now this slide will give me one MCQ. Am I understandable? Now, if I'm your examiner, I will be asking you tympanometry with stapedial reflux. What is this known as? Anyone who can tell me? Dr. Divya, very good evening, beta. Very good evening. Tympanometry with stapedial reflux. This is known as impedance audiometry. We use a word, impedance audiometry. I want to give you a strong message. At the last, we have to play aggressive. The way I am delivering all the important MCQs to you, the way I am teaching all the topics, this speed is the need of our beta. Not only for examination, just remember beta, those who are fast learner, they always win the match. They always win the match. So we have to be very fast learner especially in the last spell. Read in a very fast go. Clear? Now what I am showing you, examiner, 3 important points. This is perichondritis. What is the bacteria? Perichondritis, malignant otitis externa. Bacteria is Pseudomonas. Normally in ENT it is Streptococcus, but here in perichondritis it is Pseudomonas. In malignant otitis externa, malignant otitis externa is the topic. Is the topic. MCQ have to be there. You can make a star over this topic. This year I am expecting one MCQ on malignant otitis externa. Diabetic word will be there. Clear? So in this patient, the patient will be diabetic patient. Patient will come to you with ear discharge with facial nerve palsy. Just remember this point. Ear discharge, facial nerve palsy, 2 MCQs. What is the investigation of choice? Anyone who can tell me? Very good, Dr. Prem. Diabetic patient. What is the investigation of choice? I will be going for technetium 99 scan. And if examiner asks you the prognosis, is gallium scan. So diagnosis is technetium scan, gallium scan is the prognosis. I will be asking you what lab investigation you are using in medical college for prognosis. So you will reply it is ESR. We use erythrocyte sedimentation rate. Within how many weeks it comes down? It comes down within 2 weeks. Beta kaam ki baat ye, we have to memorize these, revise these words again and again. What is the treatment of choice? Treatment of choice is medical treatment. We give 3rd generation cephalosporin, drug of choice for malignant otitis externa. Then examiner can give you one MCQ. This combination, what I am showing you, this is a rising curve. Can you see? Always facial nerve palsy. Most commonly cranial nerves are involved, and which is the most common cranial nerve involved is your facial palsy. Then after otosclerosis, one important topic for your FMG examination is your Meniere's disease. So examiner will be showing you a rising curve with electrocochleography finding, where he will tell you some summating potential, action potential ratio is more than 0.45. So rising curve with electrocochleography finding is your Meniere's disease. Beta. Meniere's disease common in male in the age of 30 to 40 years. And what are the important findings of Meniere's? Patient will have, the first symptom will be ringing sensation in the ear, then vertigo, then sensory deafness and fullness of ear. What is the treatment? Again, we are going for medical treatment. We go for dietary modification. Patient respond, more than 70% of the patient respond by dietary modification. Meniere's and malignant otitis externa, always remember, we go for medical treatment. What are the other point they can ask you on Meniere's? They can ask you which graph, rising curve will be there. Low frequency hearing loss is a feature of Meniere's. What is the other name? We call it as endolymphatic hydrops. Which surgery we people do? Endolymphatic sac decompression. Which drug we can use in the resistant cases if the patient not responding to endolymphatic sac decompression? It is not high frequency beta, Dr. Meet, it is low frequency which are involved. It is low frequency. And if patient, they can ask you not responding to endolymphatic sac decompression, last option, I can inject gentamicin in your round window. Clear? Intratympanic injection of gentamicin. Okay, so this slide is dedicated for Meniere's. What I am showing you now, this is something to do with BARA, brainstem evoke response audiometry. Always remember, BARA is an investigation of choice for neural deafness. If the patient have neural deafness like acoustic neuromas, like any 8 nerve pathology, we will be having brainstem evoke response audiometry. They can ask you the pathway beta. This question was there in your NEET exam. This question can be there in the FMGE ECOLIMA. This pathway should be on your tips. 8 nerve, cochlear nucleus, olivary nucleus, lateral lemniscus, infracolliculus, medial geniculate body and auditory cortex. The whole pathway should be on your tips. Which is the largest way? Yes, you tell me. Very nice. Gentamicin, yes beta, absolutely right. Your response in the chat box give a strong message that you people have revised ENT notes. Very nice. Now, which is the largest wave? Fifth wave is the largest wave. Fifth is the largest wave. Para is an investigation of choice for retrocochlear, that is sense. Now, what I am showing you, examiner in your FMG, they can either give you Antony word, Antony type A, Antony type B cells are seen, or they will give you a finding of ice cone appearance on CP angle, cerebellopontine angle. I am talking about acoustic neuromas. Acoustic neuroma, always remember. They can ask you which is the first nerve to be involved. That is your fifth nerve. Therefore, we have loss of corneal reflux. We have loss of corneal reflux. If 8 nerve is given, obviously answer will be 8. I will not waste my time on these things. First nerve, fifth nerve. If 8 given, I will go for 8 nerve. No issues. Antony classification, gamma knife radiotherapy will be indicated if patient is not interested for surgery. Just remember, what is the treatment for the given slide? Surgery is the treatment. We have to do surgery, but patient deny, I go for gamma knife radiotherapy. Clear? So these are the expected points on acoustic neuroma. What is more important point? They can ask you Hitzelberger sign. So what is Hitzelberger sign? Is your loss of sensation in the posterior superior part of extra-auditory canal. Hitzelberger sign that can be seen in acoustic neuromas. Coming on these two slides, but either they will show you this something like this. It is vestibular evoke myogenic potential. Those students, beta, if you have not touched ENT till now, And the last spell, beta, please go through this video nicely. I tried my best to touch all the expected topics. Just go through this video. Vestibular, evoke, myogenic, potential. It evaluate which part? It evaluates acute. It evaluates acute. No, beta, no, Dr. Meet Patel, before 5th, it is not 7th. 7th is resistant to pressure. God takes special care of 7th now, not first to be involved. Clear? Now, what I am showing you this, if examiners show you some fistula, some dehiscence, can you see some dehiscence over the semicircular canal? This is known as semicircular canal dehiscence syndrome, where there will be a loss of sound energy. Patient will be having conductive deafness. Superior semicircular canal dehiscence syndrome. And what is the treatment? The treatment is like wait and watch. Initially we wait and watch. If patient not respond, we go for search. We go for surgical repair. So these two slides with a VEMP and superior semicircular canal dehiscence. What I am showing you, very favorite topic of your examiner these days, conductive deafness. What is the treatment for conductive deafness? We use hearing aid. Like in old patient, we use BTE, behind the ear, full form BTE, behind the ear. This is ITE, in the ear. If the examiner show you something like this, it is CIC, completely in the canal, completely in the canal. Clear? If examiner show you something like this, a device over the mastoid, we call it as BAHA, bone anchored hearing aid. Which are the three important indication? Three indication are canal atresia, canal stenosis, and pus in the canal. Canal atresia, canal stenosis, and pus in the canal. Always remember this point. Canal atresia, canal stenosis, pus in the canal. BAHA, bone anchored hearing aid. But after this session, just do one favor for me. This slide should be on your tips. I am expecting one MCQ. This is cochlear implant. We are using in sensory neural deafness, where your 8th nerve have to be normal, intact. Why? Because it stimulates your 8th nerve. So it is for sensory deafness. What is the most common indication of cochlear implant is Mondini dysplasia. What is the lowest age of using cochlear implant? 1 year. So one MCQ will be either they will be asking you hearing aid, or they will be asking you something to do with cochlear implant. This image expected MCQ. Clear? Like this question I am sharing now. Next, the second question is child age 2 years presented with severe sensory neural deafness, was prescribed hearing aid with, but no improvement. Then next step will be I will be going for cochlear implant. This question can be repeated. One more important point, just remember, in cochlear implant we are keeping in scala tympani via round window. These are the two important MCQs where we keep scala cochlear implant is scala tympani and via round window. Clear? Now what I am showing you one slide. If the examiner show you something like this, it's your Apple's maneuver. Which topic I am talking about? bppv. This is benign paroxysmal positional vertigo. Benign paroxysmal positional vertigo. Which canal is involved? Posterior canal is involved. What happened in the posterior canal? There are loose foreign bodies, calcium carbonate, autoconia is there. Very good, very nice response. Autoconia. What is the treatment? Treatment is Apple's maneuver. If the examiner asks you diagnostic maneuver, diagnostic will be Hall-Pick. Just remember, what is Hall-Pick? The first 3 steps Hall-Pick. If the examiner asks you the treatment, it will be your Apple's. Very simple, very straightforward. Clear? So beta, these are the important MCQs related with ear. Important topics which can be there in the topic of ear. Please go through them nicely. Be confident, beta. Whatever you have read, don't touch any new source in the last spell. Whatever you have with you, revise them nicely. Coming to the next segment, a middle year post-COVID patient, newly detected diabetic mellitus patient comes to you, ear malignant otitis externa. MCQ from nose, it is your mucormycosis. They will be showing you this type of slide. It is mucormycosis. This mucormycosis, they have special love for blood vessel. Always remember, it blocked the blood vessel. Therefore, there is a necrosis over the tissue. Clear? There will be no epistaxis. This patient will be having no epistaxis. Just remember, this is a favorite tricky MCQ. The exam, a very favorite question of their AIIMS examiner. No epistaxis. There will be no bleeding. Everything is necro. So is a question of bleeding. What is the drug of choice? Liposomal amphotericin B. Clear? This question can be there. They can ask you black fungi or very simple MCQs. But expect one MCQ on mucormycosis. Clear? Coming to the next one. Which of the following? Yeah, this is something very simple. I'm showing you 3 important MCQs. Which of the following is unpaired cartilage? Which cartilage never ossify? Which of the following is not a hyaline cartilage? Which of the following is up? I'm giving you 5 important points, beta, from where expect one MCQ in anatomy. In ENT, they will not be asking questions. Paired, unpaired. Just remember, paired cartilages. Which are the paired cartilages? Arytenoid, cuneiform, corniculate. Which are the unpaired? That is your cricoid, thyroid, epiglottis. This is first important point. Which is the largest cartilage? Is your thyroid. Which is the complete ring-like cartilage? Is your cricoid. Just remember this point. Clear? Yes, Dr. Meet. Acute suppurative otitis media, ET, because it is commonly in school-going kids. So ET tube dysfunction is one of the important fact. Yes, clear. But exceptions always prove the rule. So we can't say it is always, but yes, most of the cases ET tube dysfunction is there. All of the following cartilage ossify. Which 3 never ossify? Epiglottis, corniculate, cuneiform. Epiglottis, corniculate, cuneiform. Then examiner can ask you all of the following are hyaline, except answer is same. Epiglottis, corniculate, cuneiform. Abductor, all muscles of the larynx. Which are the muscles? Cricothyroid, thyroarytenoid, interarytenoid, lateral cricoarytenoid. Beta, all these are adductor, except one muscle, that is posterior cricoarytenoid, is a abductor. Again, expected MCQ for your upcoming examination. All muscles supplied by recurrent laryngeal now, except cricothyroid. So they can either ask you which of the following is abductor or which of the following is not supplied by recurrent. Answer will be cricothyroid. So I am showing you these 3 MCQs, very favorite of your anatomy examiner. Clear? And then I am showing you 2 slides. If they show you a pathology at the junction of 1/3, 2/3, it will be nodule or polyp. How we will differentiate? If it is bilateral, it will be nodule. If it is unilateral, it will be polyp. So this is my nodule. And what is the treatment? We have to go for conservative management. Wait and watch. This is my polyp. And what is the treatment of the polyp? We have to go for surgical excision. Coming on the 7th MCQ, examiner can show you this finding. This is a typical finding of thumb sign, beta. Lateral view, thumb sign. Patient will be toxic patient. This patient is very dangerous. If patient may collapse at any point of time. Is a toxic patient. Epiglottitis, thumb sign. Never give any painful stimulus to this patient. Epiglottitis, thumb sign. Or they can show you a stipple sign and they can ask you the diagnosis. Diagnosis will be croup if there is a stipple sign. Just remember this point. Clear? Epiglottitis caused by streptococci, not by H. influenza beta. Few books mention. No, we will go for streptococci, and croup is caused by para-influenza virus type 1. So if we will go for symptomatic treatment in epiglottitis, I go for IV antibiotics. Okay, this slide very important for upcoming examination. Coming to the next one, they will ask you which organism is there. So we'll be going for streptococci. Coming to the next one, most common congenital anomaly of larynx. I am showing you 99% MCQ will be on laryngomalacia. Is the most common laryngomalacia. Omega shaped epiglottis, child comfortable in prone position, and newborn is asymptomatic. Therefore, I go for wait and watch. So if you ask me which are the 4 worth remembering point, I will say omega shaped epiglottis, prone position, asymptomatic, wait and watch. That's it. These are the worth remembering point. Or they can ask, they can show you this type of slide. If examiners show you this type of slide, it is something congenital webs beta. It is congenital webs. And if the examiners show you some subglottic area, stenos is here, subglottic stenosis, where they can ask you which classification we use. Anyone who can tell me which classification we use? We use Cotton-Mayer classification in subglottic stenosis. Subglottic stenosis. Clear? Next MCQ I'm expecting for your FMGE examination, they will show you some radiolucency. Keyword: trumpet player. 70-year-old male trumpet player having difficulty in breathing. They will show you some swelling, air-filled cavity. What I'm talking about? Anyone who can update in the chat box. This is the most expected MCQ topic. Question will be there. This is laryngocele, trumpet player. They can either ask you laryngocele, or they will ask you what is the which membrane it rupture. So it rupture thyrohyoid membrane. Very nice. Everybody is responding nicely. It is thyrohyoid membrane. It rupture thyrohyoid membrane. This is your laryngocele. Laryngocele. Clear? Question number 9. Then every student, just listen carefully now. Be confident of few dehiscence, few spaces, like Killian dehiscence is a gap between oblique and transverse fiber of inferior constrictor. These things should be on your tips. I'm showing you these important points for upcoming examination. They can ask you Killian dehiscence, they can ask you Killian Jemison space. Am I understandable? These are the important spaces between at different levels. So I am expecting one MCQ, not in ENT, in general surgery. They will be asking these points. I am confident you must have read all these important points. Again, very friendly advice to you. Before your examination, go through this session. I'll be just give 60 minutes. I promise you, beta. As far as ENT concerned, expected MCQs will be there. But go through them in a nice way. Then examiner can ask you, yeah, what is this? These are the two important topics, mandatory topics. Either examiner will show you a unilateral. I can teach you this stuff in 5 to 6 hours, but at this point of time, I will not be wasting more than 60 minutes with. I will be taking 60 minutes. I'll be giving you all the important topics. Revise these topics in the last one day before the exam. Beta, don't touch any book. Relax your mind. Peace of mind. Be confident in the examination hall. Take my word, beta. Your common sense, your logic, your confidence, they play important role. Clear? So in the last one day, just relax and go with a confident mind. Coming back, I'm showing you two slides. Either of these two slides, one MCQ will be there. Either he will be giving you a male 60 or 70-year-old patient with a unilateral neck swelling. Unilateral swelling, beta. It is unilateral neck swelling, nasopharyngeal carcinoma. Or they can show you young boy, reddish mass in the nose, 14-year-old boy, will be angiofibroma. Either MCQ will be on nasopharyngeal carcinoma or it will be on angiofibroma. Just remember this point. Angiofibroma or nasopharyngeal carcinoma. Angiofibroma, the most common presentation will be epistaxis. What is the site of angiofibroma? Sphenopalatine foramen. Nasopharyngeal carcinoma, commonly seen in Chinese population. Which virus is associated? Epstein-Barr virus. You should be confident of Trotter's triad, not Trotter's method. Trotter's method, epistaxis. Trotter's triad, nasopharyngeal carcinoma. There will be glue ear. There will be ear 5th nerve and 10th nerve palsy. In Gradnigo triad, it is 5th and 6th. Here it is 5th and 10th nerve palsy. Clear? Then in angiofibroma we do surgery. Here it is radio followed by chemotherapy. In angiofibroma, just remember, we never do biopsy. Any vascular tumor like hemangiomas, like glomus tumor, like angiofibroma, we never do biopsy. Clear? So these are the important point. What is the most common site for nasopharyngeal carcinoma? Is a fossa of Rosenmuller. Behind ET tube, there is a fossa of Rosenmuller. Clear? A very strong message I want to give you on this platform, but this speed will give you success in upcoming examination. Clear? Differential diagnosis of membrane over the tonsil. All these points should be on your tips. They will be asking you which of the following membrane bleed on removal, which doesn't bleed on the diphtherial. The beauty of this membrane, it bleed on removal. Membranous tonsillitis, streptococci, it never bleed on removal. Differential diagnosis. Apart from this, all the important points of tonsil should be on your tips. What is the definition of recurrent tonsillitis? More than 4 episodes. So this is the new definition, more than 4 episodes with a single episode of either cervical lymphadenopathy or quinsy. Quinsy is peritonsillar abscess. Clear? Then you should be master of type of bleeding, most common complication, because most common complication is your hemorrhage bleeding. Therefore you should be confident of type of hemorrhage. Always remember, venous bleeding is more than arterial. Which vein is responsible? Everyone reply in the chat box. Which vein is responsible? Peritonsillar vein. Which artery? Tonsillar branch of facial artery. Any type of hemorrhage, we have primary hemorrhage, we have reactionary hemorrhage, we have secondary hemorrhage. Primary is on table, is on table. OT table. What is the cause? We have injured a vessel. Therefore, what is the management? We ligate the vessel. Reactionary is within 24 hours. Slippage of ligature. It slip out. Slippage of ligature. They can give a typical history. Surgery was uneventful. Patient was shifted to the recovery room where there was some blood clot in the oral cavity. It is reactionary, and what we have to do, we have to take back to the patient, OT, religate the vessel, religate the vessel. Secondary is after 24 hours. It is because of infection. Treatment is IV antibiotics. On which day is commonly seen? It is commonly between 5th to 7th day. Important topic. 1 MCQ expected on tonsillectomy. Clear? Or they can ask you indirect MCQ. Patient was planned for tonsillectomy. Following the surgery, patient was having severe pain, referred otalgia. Which nerve is there? In the bed of the tonsil. In bed of the tonsil, always remember, we have styloid process and one nerve, that is your ninth nerve, glossopharyngeal nerve. Clear? So answer will be A option. These are 10 on this platform in these 60 minutes. Apart from all the important topics, I am giving you important MCQs which are expected. For the last 2 years, I am observing your examiner is fond of asking X-ray. We people prefer HRCT. In any case, we go for HRCT, but yes, they are asking the images. So you should be confident. This is Waters view, Waters view. Nasochin view, occipito mental view, that is your Waters view. For maxillary sinus, which sinus never visible? Posterior ethmoid, never visible on Waters view. Can you appreciate? Is a broader face, very broader face, Waters view. And if we ask the patient to open mouth, why we ask? To appreciate sphenoid. So for sphenoid, we ask the patient to open mouth, and that is known as Pierce view. They can ask you these important points. Very good. One of the student writing caudal is occipitofrontal. Very good. You are moving ahead. This is the need of art. Very good bit. One of the student who is replying. Awesome response in the chat box. Then examiner can confuse you between two abnormalities: cleft lip, cleft palate. So just remember, cleft lip is due to defect in the fusion of medial nasal process with maxillary process. Important definition. And cleft palate is failure of palatal process of maxilla. So the examiner can show you this type of slide and he can ask you the important MCQ. Clear? So it will be your C option, medial nasal process with palate. Clear? So just remember this point. Am I understandable? So this type of abnormality where they will be showing you. So it is medial nasal process with maxillary is your cleft lip, and palatal process of maxilla will be your cleft palate. I hope you got my point. A option. Clear? Coming to the next segment. Now, a 13-year-old boy with a low-grade fever. This type of typical history was there. The patient suffering from. Now, this is a typical history of, if examiners show you a image. Diphtherial. What is the beauty of diphtherial in ENT? One, the membrane bleed on removal. One, you should be confident. It is bull's neck. This word I'm expecting they can ask you. Bull's neck is a feature of. So bull's neck, always remember, is your diphtheria. This type of typical history will be there. What is the important point you should remember? Which type of tracheostomy we are doing? We are doing low level tracheostomy in these patients. This can be one potential MCQ. They can show you a child is having bull's neck and which type of tracheostomy is indicated if patient have dyspnea, respiratory discomfort. Clear? So we'll be going for low level. High level tracheostomy indicated for, let us use this next 1 minute for few MCQs. High level malignancy, low level bull's neck, that is your diphtheria. Best area between second and third. Vertical incision, emergency. Horizontal incision, elective procedure. If tube is blocked, completely blocked, remove the tube. If it is partial blockage, do suction. Am I understandable? These are the important points which they can ask you on tracheostomy. How much dead space is reduced? It is 30 to 50%. Which tube we are using? We are using cuff tube. Cuff tube. What is the drawback of cuff tube? Pressure necrosis. Therefore, there should be high volume, low pressure. How frequently we should deflate the cuff? Too early for 5 minutes. So these are the important points. Examiner can show you a polyp. Just remember, if age of the patient child is 2 years, less than 2 years, pediatric patient, we always suspect intracranial mass, meningocele, encephalocele. So we always go for investigation for intranasal meningocele, like we will be going for CT examination. I want to appreciate from where the herniation is there. Clear? Examiner show you unilateral polyp. This is known as Killian's polyp, enteroconal polyp, single large unilateral, maxillary sinus. No reoccurrence is there. This is multiple grape-like polyps, ethmoidal polyps, bilateral grape-like polyps. What is the investigational treatment? Is endoscopy. Investigation, if you're doing endoscopy for investigation, it is your diagnostic endoscopy. If you're doing for treatment, it is your FES, functional endoscopic sinus search. Clear? If examiners show you this type of slide, beta, this is peanut butter like foul smelling mucus discharge with heterogeneous opacity. This is allergic fungal rhinosinusitis. Heterogeneous opacity with peanut butter. These are the two keywords for allergic fungal sinusitis. This topic we have already discussed. This is your mucormycosis. This MCQ we have discussed. Mucormycosis. If the examiner show you this type of image, pinching the nose, spit out the blood, that is your Trotter's method. Epistaxis. Which artery? Yes, anyone who can reply in the chat box. Which artery we embolize? Sphenopalatine artery. They can ask you what is telespa. Okay, trans endoscopic ligation of sphenopalatine artery, Trotter's method. Question number 16. Next MCQ important point I am discussing. The very strong message behind this MCQ. Last line of the question. Which of the following finding can be associated with merciful anosmia? Beta, always remember, merciful anosmia is a key word. Is a key word for atrophic rhinitis. Atrophic rhinitis. So roomy cavities will be there associated with Klebsiella. Merciful anosmia. Drug of choice streptomycin tetracycline. Young's operation, modified Young's operation are related with atrophic rhinitis. We people are preferring injection of Teflon. These are the important points related with atrophic rhinitis. Which are the 5 worth remembering points? Merciful anosmia, Klebsiella, streptomycin tetracycline, Young's modified Young's operation, or we inject Teflon, which is known as Lawton's laser surge. Clear? Then one MCQ always from air cell, ethmoidal air cell, or swelling of the turbinates. Clear? This is very favorite question. They will show you a CT examination. In this is inferior, this is middle turbinate swell up. If they show you this type of image, beta, you should attempt concha billosa. This is concha billosa. Clear? Is here most common pathology, middle turbinate, pneumatization of the middle turbinate. Now just try to learn. I give you 3 MCQs. If they show you this, anyone who can reply in the chat box, what I'm showing you, this is floor of the anterior ethmoid. So beta, this is Heller cell. This is Heller. What is this? This is bulla ethmoidalis, and this is concha billosa. Bulla ethmoidalis, concavillosa, halar. All the three important points on a single slide. What is bulla ethmodalis? Largest ear cell present in anterior ethmoidal sinus. What is halar? Floor of the anti-ethmoidal. So beta, three words should be on your tips. Halar is the floor. Out of this, one MCQ will be there. Very nice response in the chat box. Either halar is equal to floor, bulla ethmodalis is equal to largest, agar nasal is the most anterior, agar nasal most anterior, and which is the most posterior is your anode cell. The most posterior is your anode. So this, the most posterior anode, the most anterior will be agar nasal, clear? Then examiner can show you these three slides better. Just try to learn. This is your hypertrophy of sebaceous gland, rhinophyma, potato nose surgery. What is this one? This is rhinoscleroma. Either examiner will show you this slide or he can show you this type. This is your stenosis of the nose. This is rhinoscleroma. Again, atrophic rhinitis, similar presentation, but here merciful anosmia will not be there. Here the examiner will use a word woody nose. If examiner use the word woody nose, it is rhinoscleroma. Clear? This is your mulberry like nasal polyp. This is rhinospodiosis. This is rhinospodiosis caused by rhinospodiosis seaberry. Clear? Drug of choice will be dapsone, but treatment of choice will be surgical excision. I am expecting one MCQ on rhinoscleroma beta. Woody nose, Klebsiella will be involved, streptomycin tetracycline will be there, Mikulicz cell, Russell bodies, these findings will be mentioned. I hope you people must have revised nicely. Target sign, double ring sign, this is CSF rhinorrhea, traumatic CSF rhinorrhea. If the option will be traumatic, I'll be going for traumatic CSF rhinorrhea. What will be the treatment? We prefer to wait and watch with IV antibiotics. Wait and watch with IV antibiotics. If there is no improvement after 2 weeks, we can go for repair. What is the most common cause? Surgical trauma, endoscopic trauma. If examiner asks you investigation of choice, that is electrophoresis. But if examiner asks you the site of leakage, how we diagnose site of leakage, it is your HRCT, confirmatory investigation, electrophoresis, site of leakage, HRCT. Clear? Then I am showing you one image base. This is my epiglottis. So one thing is damn sure, this is anterior. So your larynx is covered from both sides by piriform fossa. So this is your piriform fossa. What is the important point? Internal branch of superior laryngeal nerve crosses from this area. Am I understandable? This is the most common site for hypopharyngeal malignancy. But just stop writing. Just focus your eyes on the board. Learn a nice concept. Most common site for hypopharyngeal malignancy is piriform, but examiner give a typical history. 20-year-old female suffering from Plummer-Vinson syndrome, iron deficiency. Patient was diagnosed to be having any malignancy. Which malignancy? Post-cricoid malignancy. Which malignancy common in young female suffering from iron deficiency, Plummer-Vinson syndrome, post-cricoid carcinomas. Post-cricoid carcinoma have very poor prognosis. Which malignancy have the poor prognosis? That is your post-cricoid. Okay. Then I have given you one MCQ on your abscess. Abscess of the pharynx mandatory. Abscess of the pharynx mandatory. So I will write few points. They can ask you retropharyngeal abscess. What is a key point for retropharyngeal abscess? Is localized swelling. There will be one localized swelling on posterior pharyngeal wall on one side of midline. What is the lower limit of retropharyngeal abscess? Sir, it is bifurcation of trachea. What is the treatment? Sir, IND along posterior surface of sternocleidomastoid. This is the important point. What are the causes? Chronic it is TB or infected lymph nodes. But if examiner asks you for acute is because of lymph nodes, like tonsil adenoid in pediatric patient. But sometimes examiner asks you most common cause of acute retropharyngeal abscess in adult. In adult, if the examiner asks you, you will go for surgical trauma. Tip of my endoscope damage the postpharyngeal wall. Examiner can ask you parapharyngeal abscess. So in this MCQ, let us crack this one. Examiner is using the word diffuse, not localize. If there is a localized swelling on the postpharyngeal wall, it is your retropharyngeal. But if it is a diffuse swelling, it will be prevertebral abscess. Prevertebral abscess. Parapharyngeal abscess, there will be a swelling in the lateral wall of neck, not on the postpharyngeal wall. In this patient, tonsil will be pushed medially. Tonsil will be pushed medially. Which other abscess tonsil is pushed medially? Peritonsillar abscess, quinsy. But in quinsy, you will not be having neck swelling. Here, I will be getting a neck swelling. And what is the treatment? Will be again ENT. This is my parapharyngeal space. All the important structures are there. Pterygoid muscle, carotid artery, jugular vein, 9, 10, 11, 12 cranial nerves. So depending on the area, you will be having symptom. Just remember, tonsil pushed medially with neck swelling is parapharyngeal abscess. They can give you one keyword, woody swelling. Woody swelling below the chin. If there is a woody swelling below the chin, it is your submandibular abscess. So one MCQ from abscess expected. What is the cause of submandibular abscess? Is your dental infections, premolar, molar. So these are the important points. What is the lower limit of parapharyngeal abscess? Retropharyngeal abscess is up to bifurcation of trachea, while parapharyngeal abscess is up to hyoid bone. Aim of this session was only to give you a thought process. Okay, beta, believe in yourself and you will succeed. Take my words. Fast learning, never be slow. Adapt to the scenario. Those students who will be adapting to a scenario will be definitely getting ranked. Next day is better, no excuse, nothing. I'm understandable. Show gratitude. If you are having no gratitude, take my word, don't expect anything. Show gratitude to the God. Whatever resource you have, whatever you have read, whatever notes you have with you, just revise better. Revise them properly. Don't touch any new topic in the last day. Work more on your confidence on the last few days. Whatever you have read till now, just revise. Very good luck, and I am confident all the students listening to me will definitely cross this FMGE examination. Very best wishes, beta. Thanks a lot.